good afternoon, good evening, or good morning, depending on the place on earth that you are attending this fourth webinar of i-Violin project that is a EU-funded project. And this is a task from Work Package 7 about education training on image quality evaluation tools and corresponding optimization. My name is Cristiano Paulo. I'm the Work Package leader of this i-Violin project, and it's a real privilege and honor to be here today to moderate this last episode of the i-Violin webinars. i-Violin project has several other members, a huge consortium with several other universities and hospitals that are here in this PowerPoint, which I would like obviously to thank each one of them for the involvement and for the success of this project. The Work Package 7 has the objective to develop an education and training program for radiologists, radiographers, and medical physicists on how to implement optimization programs in CT procedures, including the use of image quality evaluation tools in view of reducing the exposure of oncological patients to ionizing radiation. The education training program is built in a multi-professional integrative approach involving what I call the radiological family as a strategy to stimulate teamwork and increase patient safety. This education training program is based on several other EU-funded projects, namely MEDREPET, Euclid, MEDIRAD, and Euramed Rock and Roll, which was one of the latest, and as expected, the involvement of the European professional societies, such as the European Society of Radiology, the European Federation of Radiographer Societies, and the European Federation of Organizations of Medical Physicists, which obviously I would like also to thank for all the work they have done on the benefit of the professions and on the patients in Europe. We have several specific aims, especially is to develop knowledge, skills, and competences in optimization of CT, to define a methodology on how to include image quality evaluation tools in daily practice, which I think is very, very important, and to increase interprofessional teamwork. And also to develop a European education and training program that can be usable all through EU hospitals. And obviously to create synergies and collaborations with European and international organizations. These were the four webinars that were proposed, and today we are in the last one that we will start in a minute. So for today, we have three outstanding speakers that will drive us through this journey about how to use modern dose reduction tools, how to use them in clinical practice, and then we will end this series of webinars with looking a little bit into the future, especially about the role of artificial intelligence in patient dosimetry. These are the learning outcomes, and obviously I need to thank all the three speakers that I will present when I give them the floor for joining us. Mika Korzinimi from Finland, Martin Weber from Denmark, and John Damilakis from Greece. And again, a special thanks for all the WP7 members. By saying this, we will go immediately to our first speaker today. Our first speaker is Dr. Mika Korzinimi, a medical physicist from Finland, from Helsinki University Hospital. He's very well known, also very active in EU projects and EU activities. Thank you, Mika, for joining us, for being with us today, and especially a special thanks for all the excellent work you have done in Europe as a medical physicist in several other projects, and especially, for example, for Eurosafe, where you have helped us a lot in promoting radiation protection, which is something that you have been done in the last years. Thank you so much, and the floor is yours.
Thank you, Graziano. Very kind introduction, and I'm happy to be here talking to you. And I will start my presentation soon. I will just share my screen. Okay, hope you see this now.
Perfect.
Thanks. So I will be talking about the proper use of modern dose reduction tools in CT. And here you can see my learning objectives. So I will briefly go through the main tools that we have for dose optimization, like tube current modulation, automatic tube voltage selection, and organ-based tube current modulation. But obviously, I will go through with many other tools as well. So I will briefly outline the whole field. So if I look this from the perspective from Helsinki University Hospital, where I work, we have observed steadily increasing numbers of CT scans during the past few years. So it's really been growing. The three-dimensional imaging in radiology and also outside radiology is obviously more and more popular. And also it involves increasing amount of work for radiologists to go through that huge amount of three-dimensional data. And also, actually, it increases the technical demands for our PAC system to really take in that huge amount of digital data. In one CT exam, you will easily get a gigabyte of data. But what's more important for the topic we are talking now is that CT contributes majority of overall radiation exposure in radiology. In Finland, it's roughly 70%. So it's really a huge number. And luckily, we have technical developments that help to optimize these exams. So if we think about the dose and image quality factors, we have many parameter connections between the typical imaging parameters like voltage and current time, products, MAS. All these can be either directly or indirectly linked to the radiation dose. But what's more important is also how it affects the image quality. So we can describe that usually by contrast, noise, and resolution. And these parameters also have their connections to the imaging parameters. Like contrast is related to voltage, obviously, and also the contrast agent, but also other factors like beam shaper, which is linked to the patient centering. So we have to take into account how the patient actually involves this whole equation. And the individual physiology and anatomy of the patient obviously has a link on how we can reduce the dose, how it affects to the final image quality, taking into account the imaging protocol. And what I'm going to talk about is the importance of very practical, simple aspects as centering of the patient, which affects to the dose and the image quality. The length of the scan, number of series, which have a direct implication on the whole cumulative radiation exposure of the patient. But nevertheless, it's the image quality which plays the major threshold here. Without adequate image quality, the dose aspect and dose reduction is actually meaningless. We also have to think about how we define and how we reach the image quality which is adequate. And there we have to speak about the indication, why the exam has been made. And that can also be related to the diagnostic reference levels, which we can use in combination with dose monitoring software, which has been a topic in the previous webinar. So as an example of this indication-specific aspects, not only for image quality, but also for dose, here are examples of indication-based DRLs for CT in Finland. So in addition to typical anatomical DRLs, we also have indication-based ones. And these are stated by the usual dose parameters in CT, traditional CT-di-vol in milligrays, in dose length products, milligrays times centimeters. But in the future, to make a meaningful optimization strategy, we should use more relevant parameters for dose and image quality, of course. And regarding the diagnostic reference levels in dose side, we should preferably use parameters that take into account the patient size. So size-specific dose estimates, or SSDEs, are increasingly important. As you can see, the dose distribution in the cylindrical phantom is quite smooth and quite different from the highly heterogeneous dose distribution in the patient in this helical scan. And therefore, we understand that CT-di-vol, which is described in this standard cylindrical phantom, is not a good surrogate for patient dose, at least for not all the patients. So that's why we have to use more meaningful parameters. If you do that in connection with the dose monitoring software, here are some examples from our hospitals describing CT head doses in different parameters. So we have the traditional dose length products, CT-di-vols, but we also have size-specific dose estimates, or SSDEs, and also effective doses. So we can have more comprehensive set of parameters to describe our doses and also manage them in our pursuit for dose reduction. Here you see in the red our national DRLs. What I would encourage you to do is to have also your local DRLs to track more tightly into your local practices, and then compare your local medians to that. But there are more about the dose reduction tools and how to appropriately use them in dose monitoring software than just doses. Dose monitoring systems are becoming more and more comprehensive tools for optimization. So they are extending to protocol management features where you can evaluate and harmonize exposure and reconstruction parameters. So when you find some maybe outlying doses for some unit, you might want to explore more deeper why the doses have been deviating from the typical ones, and find reasons for that in terms of basic exposure parameters. So it's helpful to utilize the whole big data that we are currently having in radiology through this monitoring software. So in a sense, when we talk about the new technical tools for dose reduction, we are trying to move from technical performance more to the clinical relevance, to find parameters that are more meaningful in the patient-specific optimization. And at the same time, instead of just looking at our imaging quality as an average number, we should be trying to achieve consistency of quality, which means reducing variability in those patients' specific parameters, which take, for example, patient size into account. So there we can have more consistent tracking. As I mentioned in the beginning, one of the most simple ways to improve optimization and to have a meaningful imaging exam is to take care of patient centering. patients should always be carefully centered to the scan isocenter. An important reason for that is that CT scanners have beam shaping or bow tie filters, which modify the beam during the rotation of the tube. And it assumes that the target, which is the patient, is cylindrical and centered appropriately. So it's a very simple thing, but important to remember. And there are different sizes of bow ties depending on the vendor of the CT scanner. And pediatric scans should apply smaller beam shapers as provided and recommended by the CT manufacturer. Luckily, many of the modern dose reduction tools have been automized. So we have centering tools like 3D cameras, which facilitate and automate correct patient centering in many new CT scanner models. So they sort of are installed above the patient. They see when the patient is positioned, and also they incorporate typically and increasingly artificial intelligence algorithms to also sort of estimate and approximate the correct anatomical scan ranges. But nevertheless, the wrong centering of the patient leads to deviations in the other automated tools like tube current modulation and also tube voltage selection. So they are important for dosimetric purposes and also for image quality. And actually, this image shows the effect of miscentering in vertical direction, how it reflects the scout image. If the patient is too high and the tube is in a PA position, obviously the patient is minificated in the scout image. And then again, if the patient is too low from the isocenter, the patient is magnified in scout image. And that magnification obviously affects to the amount of MA that the CT scanner tries to achieve during the actual CT scan. So from here, we can actually move to maybe the most conventional already and used dose reduction tool, which is the automatic tube current modulation, which enables consistent CT image quality and also related dose saving. So the tube current modulation typically utilizes the scout image or planning radiograph image of the patient prior to the scan and plans the tube current during the scan from each slice and from each angle of the X-ray tube, so that we should achieve consistent image quality, for example, in related to noise seen in the image. And it's quite an easy traditional mathematical relation described by Poisson statistics that the noise is inversely proportional to the square root of the dose. So we can roughly estimate how the image noise behaves in different dose or exposure levels. But it's always important to reflect that to the clinical need. What is indicated in the scan and what is the adequate image quality in each case and protocol? So to use those modulations properly, we should use conscious decisions by multi-professional teams, meaning radiologists, medical physicists, also radiographers together on the tube current modulation settings. And there are many names for that in different scanner vendors: noise index, standard deviations, dose right index, so forth. And we should remember to take vendor recommendation into account. For example, how to actually compile these scout directions. There are also other variants of tube current modulation, as the dose reduction in cardiac CT scan with EGG-gated methods. In the old-fashioned retrospective gating, we had continual exposure and the targeted reconstruction phase by ECG, typically in diastolic or end systolic phase. But when we want to reduce dosage to the patient, we can just concentrate on the targeted phase of the cardiac cycle and find our reconstruction window within that. But then again, we should know our typical scanner model. There are many variants of the gating. We can use reduced but non-zero MA at the non-targeted gaze, or temporal buffer around the targeted phase of the cardiac cycle. So we should be well educated in the training of our scanner to know how that specific model works in the cardiac scans. Then we have the yet another variant of tube current modulation, which is the organ-based tube current modulation, mainly protecting anterior radiosensitive organs like breast, thyroid, and eyes. Also there we have differences in different scanner vendors. Some use the same roughly 90 degrees angular range for dose reduction for the entire scan range. Some have more specific regions in Z direction to protect radiosensitive organs. And they might have different angular range up to 180 degrees to, for example, protect the female breasts during the chest helical scan. So we should use these different tube current modulations according to recommended practices by the vendor. Now we know that the attenuation of X-rays is different with different photon energies. So when we change the tube voltage, we have attenuation differences changing accordingly. With a higher kV, we have increased photon energies, decrease in the attenuation coefficients, and accordingly, we have less contrast in the image, as the Compton effect dominates increasingly over photoelectric effect, which brings contrast. So there are many ways to manage this, and we can also exploit that in dual energy CT scan, where we can use material differentiation by this phenomena. But when we think about that, we have to take a balance between different sizes of the patient and our possibilities to improve contrast, for example, by iodine. So if we change from 80 kV to 140 kV in this phantom image, we can clearly see how the contrast changes and decreases, and the same effects applies to the patient images. So with iodine, typically the less kV is good. However, we have to take into account what's the performance of the scanner. Can it really bring up enough MAs to image the larger patients also with this iodine contrast with a lower kV? So it depends on the many factors, like your scanner model again. Luckily, also tube voltage can be automatically selected by these dose reduction tools. So in a nutshell, how it works is that we take the topogram or scout image of the patient. We have automatic calculation of the net attenuation profile. From that, the scanner calculates for each kV station the tube current modulation curve. And finally, it chooses the most dose optimal one, because these different curves have the same image quality already calculated in. So we can automatically select for each patient based on their net attenuation an optimal kV, taking also into account the contrast that we have. Do we have iodine how much do we have it, and so forth. But what's most important is the relevant image quality, how the image can be used for the intended task. And for that, we have also those indirect means to improve dose reduction by a better image quality or image improvements by iterative reconstructions, or recently by deep learning reconstructions or restorations. So this same image and raw data has been used in all these three images. If we think and compare the traditional filtered back projection to iterative reconstruction and deep learning, we see in these brain images how the noise is clearly reduced. Very simply, this could correspond to significant dose reduction. But what's important is the possibility to improve image quality with these methods. So take into account what is possible with your CT scanner and how it's recommended to use. And then you have the proper ways to utilize these dose reduction tools, also in the image reconstruction side. When we improve or manage image quality, or we try to reduce dose to achieve better optimization, it's important also to monitor not only the dose levels, but also image quality. And the dose reduction tools can be supported with a concurrent and parallel clinical image quality evaluation. And the modern tools also incorporate deep learning or artificial intelligence-based image quality measurements. And this is an example from our study for head CT image noise measurements, where we have the noise map of the head automatically calculated from head CT images, and the automated segmentation to give noise numbers specifically for white and gray matter of the brain. So it can help to achieve more meaningful measurements and monitoring of the clinical images. The artificial intelligence is a large topic and exponentially developing. I'm not going further into this, and John is talking later about the AI tools for dose reduction and optimization. But just want to mention that actually there are AI tools already incorporated in helping the patient positioning, in centering, scan positioning, protocol selection, parameter selection, and image reconstruction side. So there are many possible ways to utilize these generic methods, and there are more and more algorithms coming up all the time. We should not neglect other ways to use CT in the way of cone beam CT in the interventional and dental side. Here is an example of our study for EVAR, endovascular abdomen aneurysm repair procedure, where we actually achieved 90% dose reduction just by going and looking to the indication. So if we only need to see the stent in the patient, we can really reduce the dose. New photon counting CT is the technology of its own. So I briefly just mentioned that while we have a better resolution, hugely better resolution, lower noise by eliminating the electronic noise in the images, inherent spectral capabilities, and boost of iodine contrast, we can have many separated benefits for CT scans and image quality. These might sound as an incremental benefits as stated separately, but when we combine them together, it's quite significant effect. So it's exciting times. So in the end, here is the summary, so-called CT optimization cookbook, which start from the basics. We should have referral guidelines in order, appropriate justification to avoid unnecessary exams. In the user levels, we have scan settings to minimize radiation exposure by avoiding extra scan series, minimizing scan length, which is always important way to remember, centering of the patient, using these automated methods and reconstruction settings. And then when we have more modern equipment, we have improved physical possibilities for CT scans. But remember easy ways to improve things. Have unified protocol naming and coding, because then it's easier to go into the indication-specific optimization and also utilize the results of the dose monitoring software, and also maybe utilizing the clinical decision support to help the justification gatekeeper process. So use the data that we have. These might all look like incremental steps towards the lower doses, but when we combine these steps, they become significant. So we have automated tools for MA, spectral optimization, reconstructions, and so forth. When we utilize that, we can have significant improvements in CT imaging. So with these words, I will thank you for your attention. Thank you.
Thank you, Mika, for this outstanding presentation. I will kindly invite you to stay with us at the end because we will have the question and answers at the end. And by this, I would like to ask all the participants that please put your questions on the Q&A area of the Zoom. And at the end, I'm sure that we will have a fantastic discussion. With no further delay, we will pass to our next speaker, which is Martin Kask. Martin, good afternoon. Welcome to this webinar. Thank you so much for joining us. Martin is a radiographer, still young radiographer. It goes back to 1998. And he was working in CT, both in clinical and research. He has a master in medical imaging from the University of Southern Denmark, and has recently completed his PhD at the University College of Dublin. Congratulate you, Martin, for that. And where his research subject was dose reduction in functional cardiac CT. And he's now at the Eastern of the Hospital of Southern Denmark, Esbjerg. Hopefully I pronounced it correctly, where he's holding a postdoctoral position. Martin, the floor is yours for the next 25 to 30 minutes. And on behalf of Work Package 7 of i-Violin project, thanks so much.
Thank you, and thank you for the opportunity to present at this exciting webinar. I hope you all can see my screen, and I know that Dr. Kotisniemi is a hard act to follow, and some of the things I say will be supplementary or overlapping with what he's presented, but that might be a good thing. You can never hear important things too often. So this webinar series is focused on oncology, and there are numerous scans in oncology. And when we think oncology, the most common ones that comes to mind are the diagnostic and follow-up scans, which have a request for a reproducible scan range and image quality, because you need to follow the progression or regression of disease over time. But then there are also secondary scans for side effect monitoring. And a lot of oncology patients actually undergo acute and unscheduled scans, where there's more scope for adapting the dose to the clinical situation. And then there's also radiotherapy scans for planning purposes, and of course CT-guided interventions, which I will not cover in the interests of time. And in principle, there are lots of dose reduction tools. I think that Dr. Kotisniemi provided an excellent overview of their interaction. And some of those are, as mentioned, the automated tube current modulation and tube current selection, and also the organ-based tube current modulation. Iterative reconstruction, there has been said a lot about that. And in itself, it's not a dose reduction tool, only if the improvements in image quality is translated into dose reductions, which is not always the case. And recently, spectral filtering, as was briefly alluded to, has also become a physical dose reduction tool. But I would still venture that the most important tools, in inverted commas, are the radiologists and radiographers, because we may be able to monitor dose in a population, but when faced with the individual patient, we are the gatekeepers of each and every patient getting the correct dose for the correct diagnosis. And we can only achieve dose reduction if this baseline image quality that we use as input to our dose reduction tools is critically evaluated and adjusted to the clinical task, and of course, if the exam is justified. And then we need to operate the tools correctly, which was the topic of the previous discussion, and know how it works and how sometimes it doesn't work and what limitations there are, because there are limitations. We need to have operator feedback from the modality and transparency as to what goes on behind the scenes. And we need to be able to correct unintended functionality of these tools. And there's a huge role for super users or admins to set up protocols correctly. And of course, we need to have consistent IQ delivered. And importantly, you know, oncology imaging is quite a busy trade. So any dose reduction tool that interferes with the daily practice taking up more time is probably not going to be used. So I'll jump right into the automated tube current modulation. And in itself, it is not a dose reduction tool. Rather, it's a tool to ensure that the image noise is relatively constant throughout the patient. We have a task, we have some lesions that we wish to see, and based on our image quality evaluation and audit, we settle on a noise level that's acceptable to diagnose lesions of a given contrast and size. And the patient varies along the C direction, the longitudinal direction, where the we can modulate the dose according to the patient diameter at various positions, and also account for the angular difference when the tube and detector rotates around the patient, which can be based either on localizer or the previous rotation. Mostly, these two modulations are combined into a single modulation curve, which could look at this for chest, abdomen, pelvis, CT. But in older scans, you're actually forced to choose between the two, and then you have to focus on selecting the most appropriate one based on which direction the anatomy varies the most, either angular or longitudinal. One important input, as I started by mentioning, is the image quality parameter, and there are vendor differences there. Some vendors operate by what's called the reference MAS, or an IQ level, or a DRI, which stands for dose right index, which is a parameter. If you increase it, then the noise goes down. And those systems based on the noise parameter called the SD, or noise index, which is GE and Canon. Actually, the functions, the IQ parameter functions the other way around. If you increase the noise index, or SD, the noise goes up. So it's important to distinguish, especially if you operate in a department with more than one vendor. And you should also know what's considered a reference patient. What is the normal patient, which is typically based on either a reference diameter or a given weight height combination. This you can find in the vendor's manuals. It's also important to know that in some scanners, adjusting the reconstruction parameters of the first recon job actually influences the dose modulation. If you see here on the right, a study by my colleague who examined the effect of model-based iterative reconstruction. As you can see here, if you change the reconstruction level, iterative reconstruction level prior to scanning, it actually affects the final dose, regardless of what was the desired noise index. So beware that there are differences between vendors, which may or may not be important. Your super users or admins will likely have performed some setup in the background, such as imposing limits on upper or lower MA limits, or their adaptation strengths, i.e. the slope of the dose increase or decrease relative to the reference patient size. And you see here on the right, the lowered curve, it's a dose curve for a chest, abdomen, pelvis scan. You see it's almost a flat line, which indicates that the lower MA limit was set too high, so it's a thin patient, so the system was not able to modulate below 50 MAS. So we did not utilize the full potential of the dose modulation. So based on what is set there, you can either over or underexpose your patient. And sometimes you may even want to adjust the KV, the pitch or rotation time to account for upper or lower tube MAS limits. Importantly, you should also always inspect, if possible, what this system aims to do with the dose during the scan. And sometimes you have a table of proposed MA values, and sometimes you get a graphical curve, and you should always check to see if this curve corresponds with the expected behavior as to the patient attenuation along the C-axis. And sometimes you run into patients like this, and you come into conflict with the upper limit of the tube. So what goes on then? And that also is different from vendor to vendor, especially if you do multiple phases back to back, you generate a lot of tube heat. So what goes on? Some scanners actually, if properly set up, adjust the scan time or keep scan time constant and reduces the MAS to actually result in reduced image quality. And all this is set up sort of behind the scenes, and you should know what are these limits, because either you risk running into a scan that's so long that the patient is unable to hold his or her breath, or you end up with reduced image quality to the diagnostic task. Another important thing to test is what goes on if you put metal into the scan field. This is this came about. This is an old study, but I believe some of these scanners are still around. We started by looking at these curves and noticed some funny aberrations that when we put in the gonad shields, which we luckily do not do anymore, then different scanners behave differently. And even if we just had a gonad shield placed 2 centimeters distally to the scan range, the GE scanner examined here actually increased dose by 12%, while using the Philips angular modulation actually increased the total dose by 2.5 times, which just by inserting the gonad shield into the scan field. And you should be aware of what goes on there. This could also happen, for example, if the patient has a hip implant or some other non-removable metal implant. So please check what is your scanner, how does it work in the presence of metal, and maybe consider leaving the metal out of the localizer scan. Surprisingly enough, also the direction of the scan, which is you perform, is not without consequence. You see here an image of a phantom scanned in the feet head and head feet directions respectively, and you see here the green and yellow curves. that the dose distribution along an otherwise uniform phantom is different according to the scan direction. And if this is the patient's head end, you either run the risk of overexposing the breast tissue or getting excessive artifacts at the top of the liver. It's unavoidable, but please do it the same way every time, because otherwise you will not be able to pinpoint what may be the source of any artifacts or unintended breast dose radiation. So keep this stuff constant. And also something that was briefly mentioned is that if you do the localizer scans in a particular order, this may have a significant influence on what the dose ends up with. You can see here, this is one thing that we discovered, is that 2 identical protocols that were set up with different combinations of localizers actually ended up with a huge difference in effective dose delivered to the patient. And also, you can see here, we tried all the combinations of localizer sequences, and if you go from AP plus LAT to lateral plus PA, it's almost a 30% dose increase. And it's not a problem if you do it the same way every time, then you can adjust your reference MAS. But if you think you're should ad hoc adjust the order or direction of the localizer, then you may end up with unpredictable results. Again, this is vendor specific, and it also differs from software to software version. And then we move on to automated tube voltage selection, which utilizes the fact that we can get more contrast out of our images at lower kVps. You see here at the top, we have reduced the dose by simulation by MAS decrease alone. And in the bottom, we have achieved the same relative dose reduction, but by reducing the kVp instead. And you see here the liver lesions are more conspicuous due to the K-edge effect of the iodine contrast. And as you can see, we can still visualize, even in the presence of more noise, we can visualize this small liver lesion at the same dose, which would require almost double the dose at 120 kVp. So what we're going for is the constant contrast to noise ratio, which can be low or it can be high. And again, it's dependent on the task and the anatomy we wish to image. What is our desired contrast to noise ratio? We cannot input that directly into the protocol, but we can tell the scanner what to expect in terms of the iodine content in the images, because we'll get more Hounsfield units per millisievert the more iodine we pump into the patient. So we need to tell the scanner what we do, and this is the Siemens solution, where you can tell the scanner everything from a non-contrast scan to a angiographic scan with a high iodine content. And actually what this does is simply to increase the MAS, which is necessary to achieve the same contrast to noise ratio of the less contrast we use. This system selects the lowest possible combination of milliampere and tube voltage to provide the desired image quality, which can be defined by the MAS and the reference kV. So basically what we say is that regardless of kV choice, we want our images to look as if they were acquired at 120 kV at 210 MAS in this case. Some vendors also allow for semi-automatic operation of the ATVS, where the MA is adjusted, but you decide what is the desired kVp, because the the effect of noise with KVP is not linear, so it's rather hard to predict when doing manual adjustment. But if you want to reduce the contrast media, as in this case, you have an insufficient IV access in a patient with nephropathy, you can tell the system that you want to scan at 80 kV, and then it will adjust the MAS to achieve the same contrast to noise ratio as that's specified by your reference KVP and your reference MAS. And it's hardly surprising that the ATVS selects the higher KVPs the larger the patient gets, but it may also be affected by the scan range because it's an average of the dose exposure throughout the scan range. So if you only scan a high density area like the abdomen, you might end up with 120 kVp, and if you scan also include the lungs, then the system may select 100 kVps instead. This also, as was demonstrated by the previous speaker, that centering affects the automated tube current selection will also or can have effect on the automated voltage, tube voltage selection, which means that if you're not careful about centering, then you may end up scanning the same patient at different KVPs from visit to visit, which may lead you into some problems unless your specialist has set up some limits, which again goes on behind the scenes. What is the baseline KVP from which your image quality is estimated? There may be limits on what KVPs you can select, what range you may select, or individual KVPs. Sometimes it's also, you can force the scanner to use the same KVP in all phases, because not doing so can lead to some unintended consequences. In some scanners, it's anatomy specific, as in this case from Canon, or head, body scans. And if you check the contrast tag, then you have different possibilities of allowable KVPs. Or it may be programmed into every single protocol, such as this. You see here, in this case, the system is limited to not go above 120 kV. So this is important knowledge to anyone operating a system. You also have some limits on how much scan time increase can you tolerate, and what limits on dose reduction can you tolerate in terms of increased image noise. Some unintended consequences may also be that if you're scanning patients with metal, do the ATVS react to that? Because as you all know, metal creates severe photon starvation and beam hardening, and scanning at low KVPs may worsen these artifacts. So please be aware of that. If you reduce the contrast volume, then you actually reduce the contrast to noise ratio, and then you either need to adjust your contrast slider, increase your reference MAS, or consider changing your, if possible, your ATVS to semi-automatic operation. If you're not aware of this, then as you see on the right, the system may actually select, because you have a scan protocol set up with different image quality requirements that selects 120 kVps in the non-contrast scan and 100 in the contrast scans, and that may be fine unless you wish to have absolute HU value measurements in, for example, in wash-in, wash-out studies, where you need to examine the exact Hounsfield increase or decrease between phases. So in that case, you should be careful that all your phases are performed at the same KVP. There's the organ-based tube current modulation, which the previous speaker also mentioned. You have actually what I consider also to fall in the domain of OTCM is the C-axis, where you can specify different image quality for different regions, or you can have the rotational one where the dose is reduced in the anterior direction, for example, to reduce breast or eye length doses. And this is an example of the C-axis organ-based tube current modulation. It has various names, and there are various number of areas that can be defined. This on the right here is an example of the Canon variable helical pitch, where you can define 3 ranges with different desired SD values, and you can concentrate the high dose where it's most needed in the soft tissue organs. And you could combine it with automated landmark detection for a suggestion of which scan ranges are appropriate, but you should always double check, because you may have unusual organ placements, i.e. you might have a transplant kidneys located in the pelvis, and if you, in this case, it would be in the low or medium dose area, which may compromise diagnosis. But as you can see here in the study by Filon, such technology can actually reduce the dose in the lung and breast and pelvis area while maintaining a constant dose in the liver compared to using no OTCM. And this is the same as was demonstrated by Dr. Kortesniemi. OTCM has functioned very, very differently from vendor to vendor. There may be limits on scan parameters, e.g. in Siemens, you can only scan at the pitch of 0.6, which means that you have a long scan time, which may or may not be desirable. Some vendors compensate the MA outside the anterior angle of interest, and some do not, which means that the total dose delivered to the patient results in increased image noise. So which you should just be aware of it. It's not necessarily something you can do anything about. But to get the maximum effect out of a rotational OTCM, you should have a case like this, where the breasts are located within the cone of a reduced dose. But this is more realistic than some of the breast tissue may lie in the area of normal dose, and actually, for example, Siemens actually increases the dose to compensate for the reduced dose, so the breast tissue lying outside this cone may actually receive increased dosage. And then, of course, there's simple things, but equally important. You should always limit your scan range to what is important. As you see on the left, you could have ended up scanning half the volume. And on the right, you see an example of a good, careful scan planning. But you can, of course, you can also be too careful and then cut off the anatomy of interest. And in this case, the patient received 2,500 milligray centimeters and had to be rescheduled for a scan because the cyst, which we wish to characterize, was not covered. I can see that my time is running out. So I'll just skip the next slides. Just to give you one example of when you're doing unscheduled scans, you can adapt your image quality to the task at hand. And this was a patient who had an intervention, a lung biopsy, and we suspected that there might be a pneumothorax. It was a heavy patient. Supine X-ray was not sufficient, and then you can use things like spectral filtration, and you can actually perform a CT at a chest X-ray dose, and in this case, you confirm that the patient had a pneumothorax. And of course, you need to accept that you have the right indications for the scan. has there been a recent previous scan, or can you visualize by renewed reconstruction? So to omit the present scan, is there a case of crossed or multiple requests resulting in other scans at other institutions that you might require? Has there been a change in clinical information since the request was filed, or can your scan replace other radiological procedures, and is the protocol correct for the clinical task? And then select, of course, the most appropriate scanner. So in conclusion, I would like you to urge you not to uncritically transfer protocols between scanners or change recon or scans parameters pre-scan without knowing exactly what you're doing. You should on no account develop your own small rules and workarounds if you observe that the dose modulation does not give you the intended results, especially not changing the IQ parameter. And you should definitely not click the OK proceed button without reading what the scanner is telling you to. That is the problem. But you should be aware of the difference between scanners and the limits of each system that you operate. And you should always check the pre and post scan dose metrics. And if possible, you should also look at the modulation curve. Is this the right dose for this patient, for this scanner and the clinical task? And I always like to say you need to have a mental dosimeter, or call it a sixth sense, that says something like, oh, this is too high dose for this patient, or this seems like an insufficient amount of dose for this clinical task. So please always read this dose report and then store it somewhere in the back of your head to have your mental dosimeter always up to date. And if you observe any unintended behavior, you should not work around it, but report it to your responsible specialist or physicist to correct any protocol issues that may have arrived. So I would just like to direct your attention to this website, because the AAPM has some very good education slides where they describe the differences between the major vendors and their dose modulation systems, how they function, and it's very systematic work through. It's published in 22, so it may not be up to date. So I just encourage you to read the manual of your scanner, and every time you get a software upgrade, check the notice to see if anything has affected the functionality of your dose modulation. And with that, I think my time is up, and I'm glad that you watched.
Thank you, Martin.
Thank you.
Thank you so much for this outstanding presentation. I will also invite you to stay with us until the end, where we'll have the Q&A. And now, with no further delay, we will move to our last speaker of this session, my dear friend, Professor John Damilakis from the Faculty of Medicine of the University of Crete. Obviously, very well known amongst all of us. He's the actual president of the IOMP, the International Organization of Medical Physicists, a past president of the European Federation, and with whom I have been the privilege of learning a lot and working, I don't know, for the last decade or something like that. Although we look young, we work a long time together. He's head of the medical physics department in Crete as well, and very well known for developing several tools that we are using on our daily basis. So thank you, John, for all your contribution for the radiation protection all over the world. And the floor is yours. Thank you. Microphone is off, John.
Yes. Now
we need an AI tool for the microphones to understand when we want to talk.
Indeed. Indeed. So many thanks for your kind words. So the topic of my talk is the role of AI in patient dosimetry and optimization and the learning outcomes to understand the machine learning workflow and methods in computed tomography and to learn how AI can assist in CT dose optimization. So I will start from the first objective. So the pipeline for developing and implementing a machine learning workflow, the machine learning model is based on the steps shown here on this slide: data acquisition, data pre-processing, feature engineering, model selection, model training and testing, model evaluation, external validation, and model deployment. So it's a long process. Although each of these steps is important, these three steps here are more important: data acquisition and preparation. They deserve special attention. Why? Because machine learning is data-driven. No clean data, no machine learning. And we usually collect data from the PACS system. DICOM files include metadata useful for the development of those prediction and those optimization models. We need, of course, to de-identify data, anonymize, and store them in an organized way. This is very important, in a way that data can be useful for AI. In my department, we use a workstation, software, Orthang, and network-attached storage to automatically collect data from the PAC system for machine learning purposes. So it is a dedicated system, a platform. And finally, for supervised machine learning training, data labeling is needed. So I tried in a few words to describe the whole process. And I guess we are all familiar with the DICOM standard. DICOM metadata are extremely useful for AI, not only the images, not only the exams, I mean, the images, but also metadata coming with images. So what kind of data do we have? We have computed tomography images. Monte Carlo produced three-dimensional dose distributions, organ doses, DICOM metadata, and we can also easily have other information. For example, demographic data, organ volumes, tissue volumes, and so on and so forth. However, data is not enough to train a computer. We also need an algorithm. And there are several categories of algorithms. These are shown here, and each category is divided into several algorithms. Model selection is the process of choosing the best model, the best algorithm that addresses our specific problem. For example, dose prediction. This is a regression problem. Or if we want to classify a computed tomography image as a good quality or bad quality image, this is a binary classification problem, and we need to select the relevant algorithm. AI is based on libraries. These are open source frameworks. And this slide shows some of them: PyTorch, OpenCV, TensorFlow, and so on. Each library supports specific algorithms. Okay, so I will now try to describe briefly ANNs, artificial neural networks. I know, mission impossible. Within 1 or 2 minutes, it's impossible, but I will try to give you an overview, just the basic concepts. So artificial neural networks are comprised of node layers. So each node, each artificial neuron connects to one another and has an associated weight and threshold. So in this, for example, in this artificial neural network, we have an input layer, we have an output layer, and we have two hidden layers. And if the output of any neuron is above the specified threshold value, the neuron is activated, sending data to the next layer. Otherwise, of course, no data is passed along to the next layer, and in this manner, the data is propagated through the network. This is called forward propagation. The predicted output is compared against the actual output to estimate the error in prediction, and then information is transferred backwards. So there's a cycle: forward propagation and backward propagation to and the weights are adjusted. So this is a way to adjust the weights, and this cycle of forward and backward propagation continues to reduce the error of prediction. So this is a cycle, and the cycle in AI terminology is called epoch. So an epoch refers to one cycle through the training set. Okay. And we usually flatten the CT image. Flattening the image, so for example, in this case, a 3x3 image matrix, we turn it into a 9x1 vector, and we feed it into a neural network, but this is not always a good option because there is a lot of computational workload. So CNNs, convolutional neural networks, are widely used in imaging. And what differentiates a convolutional neural network from a standard neural network is that the hidden layers are convolutional layers. We need to specify the number of filters, and the convolutional layer should have, and this is important because these filters detect the patterns and images, so the layer should have some filters, and they are edge detectors. Some detect corners and whatever. So this is the way of detecting patterns on an image. And let's look here, this as an example. This CT image, and I'm just looking at one of the pixels. So that pixel has a value of 94, the central pixel in this matrix. So if you take a look at every pixel and you look at its neighbors, and then you get a filter here, which is this blue matrix, and you multiply the value of each pixel with a corresponding value in the filter, then you get a new value, and that's what a convolution is. So this is a way to extract features in an image. And this slide shows the convolution operation. So the filter moves to the right with a certain stride value, and then it goes down, hops down of the image with the same stride value, and repeats the process until the entire image is transversed. Okay, and now the next thing is, okay, if I'm planning to do lots of processing on my image, and I'm gonna have hundreds of filters to try and pick out different features in my computed tomography image, that's gonna be a lot of data that I have to deal with. So it would be nice if I could compress my images, right? So this is very important, compression, and compression is achieved through pooling. To reduce data size and decrease the computational workload, the computational power required to process the data, we do some pooling. We have 16 pixels here, and I have taken the top 4 in the top left-hand corner, and of those 4, I'm going to pick the biggest value here, 96, and then the next 4 on the next 4, and the value is 78. So I pick the biggest value, and so on and so forth. So I throw away 75% of my pixels and just keep the maximum values in each of these 2 by 2 pixels. This is a 2 by 2 pool, and that's a way to reduce the size of the image. After that, we can flatten the image and feed it, the final feed it to a regular neural network. Okay, next step. Having described briefly the neural networks, the main types of neural network, we split the data set into training set and testing set. The basic idea is that you train the algorithm using the training data set and then test the performance of the model using unseen data that the algorithm has not seen. And to validate training and adjust hyperparameters, we use several methods such as the k-fold cross-validation. Actually, this validation is the most popular to my experience. External validation, this is important to determine models' reproducibility and generalizability to new and different patients or scanners or whatever. So they may be different from different care facilities. So this is a very important process, step of the process. However, please bear in mind that in many cases, AI is not a one-size-fits-all technology. So every project, AI project, is customized to solve a specific problem. We can talk about that later during the Q&A part of this session. Okay, let's go now to the second objective of this presentation, to learn how AI can assist in city dose estimation and dose optimization. Machine learning aided organ dose estimation is one of the issues we are trying to address in the University of Crete. So we have focused on patient-specific and equipment-specific dosimetry, personalized dosimetry. And it's important to know that there is a voxel-to-voxel correspondence of those images with CT images. Time allows me to present only a few studies performed in my institution, and then I will also present other studies. I have selected the most recent. So this is a 2023 work published in Medical Physics. The network was composed of 3 layers with rectified linear activation functions. The final layer was a regression layer. As I mentioned, predicting doses, you need a regression algorithm. And this slide shows plots of deep learning predicted doses against Monte Carlo estimated doses, ground truth for 4 organs, lungs, heart, bone, and esophagus. We are all, by the way, we are always in favor of estimating organ doses. This is, in my opinion, very meaningful organ doses. And linear, very linear, very meaningful dose quantity. That's what I mean. And linear regression is shown here with a red line, and the perfect agreement is depicted with this dashed line. So the results are really good. And this is a more recent article published a couple of months ago. Our aim was to automate the whole process. This is very important, to automate the process of organ dose estimation, because the main problem, in my opinion, again, in medical dosimetry is that Monte Carlo, for example, we cannot calculate, we cannot perform Monte Carlo simulations during the everyday clinical practice. It needs time. We are all busy. So we need to automate the process. This is the best way to introduce, to implement medical dosimetry in diagnostic radiology and interventional radiology in everyday clinical practice, automate the process. And in this study, features include TICOM metadata, Hounsfield units, and the water equivalent diameter. To calculate the Hounsfield units and the water equivalent diameters, we excluded non-patient voxels by applying a mask to the CT image, and then the masked image was used to calculate the mean Hounsfield units. And also masked images were used to calculate Hounsfield units and for the water equivalent diameter calculation, which is shown in the figure on your right-hand side. This study was a first study for a small number of organs in thoracic and abdominal CT, and this is a very, very recent study accepted for publication after minor revision in European Radiology. So here we develop a fully automated pipeline capable of providing doses for many organs, as you can see, and tissues. And the code will become available. We will provide the code so users will be able to utilize the notebooks. Actually, we will provide notebooks, so those working with Google Colab, they will be able to use easily our code to pre-process their data, CT data, dosimetric data, and create arrays, the organ and tissue-specific training arrays. And this is another brand new work. We tried to answer the question, is deep learning enabled real-time personalized CT dosimetry feasible with only patient images as input? Some years ago, this would be almost a funny question. The obvious question would be no. The answer to this question today is yes. We use GANs, peaceful GANs, so generative adversarial networks. GAN is a generative model that is trained using two neural network models. One model, the generative network, which learns to generate new plausible images. So fake images, okay? Fake samples. And another network, the discriminator, learns to differentiate between a real sample from a fake sample generated by the generator, by the generative network. And training happens in parallel, in tandem. So we train the discriminator for a few epochs, then train the generator for a few epochs and repeat. And this way, both the generator and discriminator get better at doing their jobs. And this is obviously a binary classification algorithm problem for the discriminative network to discriminate between, so binary classification, to classify images as real or fake. And in our project, the generator was used to generate synthetic images, those images, I'm talking about, yeah, those images, doses. And the discriminator was trained to discriminate the synthetic images from the ground truth. And the results are shown here. The predicted images and the ground truth produced using our personalized dosimetry. And this slide shows the methodology and pairs of original ground truth on your left-hand side and synthetic images generated by applying the method. And as seen, as you can, well, I'm not sure if it is visible, but in patient C, patient C has a stent and patient D has lung pathology, and these pathologies are visible in both the ground truth and synthetic images. Again, very, very impressive. And Mika has always described the reconstruction and deep learning reconstruction already. So I will be brief. But I have to say something, because this presentation would not be complete without saying a few words about deep learning reconstruction. So with deep learning reconstruction, we reduce the noise while maintaining the texture of images. This is important, the texture. So a little bit of history here. In the early days of CT, back to 70s, reconstruction was based on filter back projection, as we all know. A filter back projection is fast, reliable, but to get low noise images, we need high doses. This is the only disadvantage of FBB is that we need high doses to get low noise images. And in the period from the 2009 to 2018, we tried to reduce doses. And so iterative reconstruction was developed. And all CT manufacturers developed iterative reconstruction algorithms, but the image texture of the images was a little bit concerning. It was plastic. There was a plastic appearance in the images. So we need fast algorithms, good contrast to noise ratio, low noise, good texture, and deep learning reconstruction seems to address issues. So vendors are currently developing these algorithms. It is a supervised learning process where the input data is a computed tomograph image generated by low quality sinogram, noisy CT sinogram. And the output image is compared with the ground truth to find differences. And the network learns by adjusting various parameters via back projection. As I mentioned previously, high contrast resolution, low contrast resolution, image noise, image texture, various characteristics. And the goal is to get through this process, through this training process, an output image that is as good as the ground truth. So after various epochs, cycles, the output image is as good as the ground truth. And again, keep in mind that the output image comes from an input image, which is an image of very low quality, low dose, but through this process, we get high quality images. I'm towards the end. I'm sure you all know ICRP. We have established a working party on AI, on radiation protection, and AI for medical imaging to monitor the developments in that field and update the commission. So this is an important, I believe, activity. Mika is also a member of the working party, Kimberly, Mahesh. So it's a nice, very nice group of team working on this important topic, ICRP team. So hopefully this will lead to a monograph ICRP book in the near future. In the future, ICRP documents take time. They are they are scrutinized, and it takes time to produce a very high quality manuscript book. Okay, one last thing, iDose. iDose is our latest tool, an AI-powered CT dose estimation platform developed within the Sinfonia European Commission projects. It is up and running, but we are currently evaluating it internally. So first we evaluated it internally in the University of Crete, and then now the Sinfonia consortium is evaluating the platform, and this platform will be available soon. So it is a matter of a few weeks or a couple of months, I'm not quite sure, depending on the feedback, and then we will launch this tool. So I cover the basics in today's webinar, some basic knowledge, how AI can assist in CT dose prediction, in dose optimization. i-Violin organizes 3 on-site workshops. And during those events, I will provide some practicals, some hands-on because of course, machine learning and AI is not only theory, but the basic concepts are needed in order to be able to go to the next step. So having said that, I will stop sharing and I'm happy to answer questions and start discussing these important topics.
Thank you, John, especially for the roses at the end. Very nice image. And thank you for this outstanding overview on AI, which I'm pretty sure that it will be on our plate for the next years, I would say. So by coming to this point, it's time now for us to go to this panel discussion. I have several questions for all of you. I saw that some of the questions that have been sent, they were replied already by Mika, especially a question about the methods commonly used to calculate DRLs by clinical indication, which Mika has kindly replied as DRLs, anatomical or indication specific, are determined as third quartile dose value from the source data. Then in clinical practice, we compare our corresponding median dose values to those DRLs. And it's you left an important message, Mika. Not only the explanation is that it helps to have dose monitoring software for this activity in order to have sufficient maximum data available, which obviously, if we join here what John showed us about AI, I think the future, especially for this part, will be quite promising. Now, so I would encourage all our participants to write down on the Q&A the questions for our speakers. But I will start because I have to say that I was astonished by the presentations. All of the 3 of them were fantastic, and I cannot leave without leaving you or requesting you to try and help the audience, and me also, because the question is from me, to understand what should be, or by on other sides, what is missing, in your opinion. And please, John, I will give you the floor for after this question is directly for Martin and Mika, and then I would like you to jump in with your AI. In your opinion, Mika and Martin, what is missing? We have so many tools. Many of the aspects that you have showed are really, let's call it very important aspects, and some of them related to basic aspects in CT. So why are these so, let's call it simple things, easy to put into practice, available for in the majority of the new equipment? Why are we still missing the proper use of the technical features of the CT scanners in the 21st century?
I think the question is for me first, or
no. First is for Martin and Mika. You will jump in because I have an add-on question for you.
Okay, sure. Okay.
Mika, Martin, you can start. Whoever wants to start.
It's a question of education, because I've been implementing like tens of scanners from different vendors, and it seems also to be a race to who has the most efficient dose modulation system. But we tested the what's the Siemens OTCM, the X-Care, when it came out first in like 15 years ago, and it was totally not ready because it actually increased the total dose to the patient. And there's a lack, in my opinion, of education. I don't think the many of the application specialists that are let loose on unsuspecting customers have the necessary level of education and deeper understanding of how their system actually works. I had a brief career also in Siemens, and yeah, they learned the company Bible, but I think there's far between those who know how their software and hardware actually works deep down. So I think there's a huge responsibility of the vendors.
Okay, Mika.
Yes, I agree with Martin, and I think there's a huge variability in the technical implementations of these dose reduction tools. So it doesn't make our life easier in the clinics. So, for example, metal artifact reduction tools to improve image quality, when we surveyed different vendor solutions, there were very contradictory results regarding different kind of implants or metal objects. So there can be huge differences in those. So I agree with Martin that education is important, and it finally boils down to the user training when you acquire new equipment. And there is, in many places, a lack of resources, quite a tight schedules. The user training may be not having sufficient focus, and that reflects to the clinical operation. Then in the manufacturer side, somehow I have felt that the very established and reliable hardware manufacturers of CT scanners have not entirely found themselves as a software developers. So there might be some quite fast developing softwares in these and fancy features, but sometimes I feel that on that side there should be more traceability and consistency. Then in the large scale, I think we have many important pieces of the dose reduction puzzle already there, but we haven't quite connected the pieces of the puzzle. For example, clinical decision support could be utilized more in the international and European level. For example, integration of iGuide to machines and referral systems in hospital information systems. That clinical decision support in referrals connected to protocoling of the CT scanners would actually feed more appropriate protocols into use. And at the same time, when we use dose monitoring systems for protocol management, we can have those protocoling systems feeding the right protocols, which also have been optimized with true data from dose monitoring. So we have plenty of big data, digital data, which should be utilized more efficiently in combination with each other. Finally, I think it would merge basically optimization and justification principles in radiation protection together. So by using this data, we have the comprehensive optimization and justification system. So
interesting. So John, passing to you, and considering what Martin and Mika, especially Mika's last words, will you help us on this with your new AI? Will AI solve the problem? There's one problem that Mika raised, and I was expecting that Martin would touch it. That has to do with the pressure in the departments to produce more and more procedures, in a kind of it looks like the clip from Modern Times from Charlie Chaplin, where we are producing at high speed velocity. So how will AI help us on this, John? And then we have a question from the audience about AI, but how would you think that the future will be to help us on these, especially on this environment that Mika brought us here?
Sure. I think Mika has already provided the answer partly. So AI will address and is addressing several issues. As I have already mentioned, dosimetry was a research topic and has been, is the correct English, has been a research topic. But soon I am optimistic, not in general, but for this specific topic, I'm optimistic that dosimetry in diagnostic radiology will become a something implemented in everyday clinical practice thanks to AI, because of the automated procedures and the capability of offering organ doses in real time. This is a rapid estimation of organ doses. This already has been achieved. It has not been commercialized, as far as I know. There is no any commercial product yet, but it is a matter of months or I don't know, 1 or 2 years to see this in the market. And obviously, the decision support systems mentioned by Mika, they will help. They are helping us in justification. i-Guide, for example, the i-Guide tool developed by the ESR is an important tool to facilitate the justification process. But at the moment, as far as I know, it is not powered by AI, and soon it will be supported, enhanced. The decisions will be enhanced by AI, and this is a game changer. I think it will change, has the potential to change the game in the justification area. Well, I don't know if of course, the AI will address issues, but will also create issues related to privacy, to ethics. There are problems related to biases, huge topics. We need another webinar to discuss about certification of products, quality control of AI tools implemented in clinical practice. I will stop here. I cannot hear you. You are muted.
I know. Thank you. For the three of you, because I have to be honest on one thing. I don't understand. When I look at Europe, and I look at the education and training of the three professionals involved, so in radiologists, medical physicists, and radiographers, I think we never had so high level quality of education training for these people in Europe. And what I hear from all the presentations that you brought here today, and we saw in the other webinars, is that we are doing more CTs and that we should. EU CT just showed us that as well, that we are doing non-justified exams. So point one, we are doing non-justified exams. And point two, instead of decreasing the dose with better technology, what we are seeing is that we are increasing the dose. So is this because radiation protection is not sexy enough to attract people to, in the daily routine, to change the mindset that radiation protection is important? Do we need to continue to pressure that, okay, toys for the boys is nice, doing a lot of exams is nice, but not taking care of radiation protection is wrong? What is happening? Three of you.
Graziano, you are very pessimistic. Compare the today's situation with the situation 10 years ago. Maybe we perform more computed tomography examinations, as Mika mentioned, but I think doses are lower. So, of course, there are problems. I mean, I fully understand your concern, and there are reasons why we are not so effective in reducing doses. And my answer is that, yes, in Europe, we have radiation protection courses, mainly educational courses. It differs. I mean, what we really need is hands-on training courses, not only theory. And at the moment, there is a lot of theory, it is difficult, I fully understand, even to find time to have a computer tomography unit only for training. This by itself is a big problem, as we all know. Busy computer tomography systems, there is no easy accessibility for training. Again, hands-on training. So this is one of the problems. And I think vendors also have a role, but they don't play that role very well. I mean that there are manuals, and have a look at the manual and how they describe all these dose reduction tools. Black boxes, in my opinion.
Yeah.
Black boxes. They keep secrets. I don't know why, to make our lives difficult, maybe. I really cannot answer that question. So the manuals are written, they are operational manuals, but they don't reveal the secrets of the tools and how to use the tools in a very effective way. So this is also partly, again, contributes to the issue you described.
Well, and I'm glad you said I'm the pessimistic.
I'm trying to I'm trying to answer your question, but I'm more optimistic anyway. Although as a person I'm not, but for this I compare because I'm older than you. And I remember before 2000, nobody was talking about radiation protection. Nobody. Americans were talking only about image quality, and it was a sin to talk about doses and risks. And then everything was changed, and we moved from to iterative reconstructions and dose reduction tools and so on. So that's why I'm optimistic, because I have experienced this process.
Let me go back to Martin before I give you the word, Martin. Just as a radiographer and being the end user of the equipment, and because i-Violin and especially WP7 is about education and training, what would be your, let's say, okay? And I understood your point, a very good point regarding the kind of the lack of the, well, they are involved, but the involvement is not what it should be with the application specialist or the vendors, and the optimization of the protocols that come with the machine that are not adapted or according to the practice in the hospital. What you said, that you don't change the protocols from one machine to another, even if it's the same brand or of the same vendor, that should be avoidable. What would be your, let's say, message for us on how should be the education and training for radiographers for this, considering that what John said, that we have a lot of education, but we lack training, hands-on practical training. What would be your recommendation?
Yeah, I would say, it's based on my experience, the management would like to have our scanner up and running in 2 weeks, and then they schedule like 2 days training per radiographer, and I think it should be more like 3 months to implement a scanner, and at least 2 weeks of training. When we transitioned from single slice to multi-slice CT in the early 2000s, we actually did this. We had, I think the scanner was running for half a year with only specialists, where they were in daily communication with the radiologists to really fine-tune the protocols. And only when these were acceptable, both from a medical, the radiologist point of view, but also from the physicist dose evaluation point of view, were the so-called private radiographers allowed to commence training. And one thing I would recommend to get, like, I would like to get a clean scanner without any pre-specified protocols, because I think in 3 out of 4 cases you just blindly accept that. I mean, I heard that so many times when people come to me with image quality problems. We did what the vendor said, and yeah. And to continue on the other problem, why do we not see more dose reductions than we should have? I think that's, we just did our latest round of DRL publications. I think that's also an important point of this webinar series, that we need to have a closer coupling between image quality and DRLs, because we get the DRLs presented and we say, oh, we're at either at the level below or above, whatever. And then there's recommendations that if you're below the first percentile, you need to look at image quality to see if it's sufficient, but no guidance as to how to do so. And actually, what I see happening, radiologists are so afraid of missing stuff, so we do not communicate that the image quality has actually not decreased with decreasing DRLs because what we saw was that we had a particular protocol that was actually way lower than the DRL, and the radiologist's reaction was, oh, so we had some sufficient room to increase our doses by 30%, which we used the same protocol for the last like 4 years with no complaints about image quality, but seeing that the DRLs were higher than what we used, they said, oh, there's scope for image quality improvement. And yeah, so that's an ongoing battle. Mm-hmm. So I think we need to couple this DRL communication with also some evidence-based on to convince radiologists that image quality it may look different, but we can assure them that they see the lesions that they're supposed to see. And a lot of the studies published on image quality it's basically just beauty contests, because you ask 3-4 radiologists to score images on an arbitrary scale. If you're lucky, you use the image quality criteria from around 2000, which is, I think, completely insufficient way to evaluate CT image quality, because you're basically asking them to state their level of confidence, and what you're confident in is what you're used to.
Yeah, that's true. Mika, any comment on that?
Well, to begin with, I think there are so many things we should do better. Beginning from the training, there are some hard facts related to resourcing. So we need management commitment to allow this to happen. I'm returning to this issue because I see it important. And the actual user training to improve the usability and potential image quality and dose reduction potential of the scanners to be really utilized, we need recurrent training. And so it's a continuum of training events. It's not just you buy the machine, you get it up and running with a hasty training, and then you just go with it for the next 10 years or so. You have to when you get an update and so forth, so you have to have a retraining and circulate that among the users. Then we should share the knowledge of our protocols in order not to invent a wheel again when we have well-optimized protocols. And if you have a larger organization, like we have plus 30 scanners, when we buy a new ones, we replicate the well-commissioned and optimized protocols from to a similar scanner model. So we try to streamline in a process way all the things that we can in order to leave more time for the human learning in around optimization. Then in the level of medical physics work, we try to automate everything we can, also including the new artificial intelligence methods as presented by John, for example, measuring image quality directly from clinical images. They help to provide data-driven decisions for optimization. So we have objective data, big data behind us. So we need multi-level solutions to tackle with these problems. And returning to your original question, I think it's a dynamic question. I think CT popularity due to new features and development has increased much faster than the ability of the user community in a diverse way to adapt to all those changes. So I think it's a matter of different time constants, if you will.
Thank you. We have a question from the audience because I have a final question for the three of you that has to do, and I probably include John here because John talked about quality assurance. And the question is, what sort of quality assurance can be implemented to assure those reading the image, so the radiologist, that goes back to Martin's point, reading the image, that erroneous information has not been introduced into the clinical images?
Erroneous information such as artifacts, for example?
Artifacts.
Yeah. This is an example. So various AI-powered methods have been developed. The audience can easily find them in the literature on how AI can help to reduce artifacts. Again, many of these studies are proof of concept, means that it takes time for those software packages to become available or to be incorporated into various systems. But it takes time. I mean, everything takes time. Even those reduction tools, it took time, a lot of time from the prototype to the final product.
Yeah. One final question, I think it's a quick answer, can go to Mika. In your opinion, what is the best way to test MA modulation system? CAT-FAN phantom with and without annually, that's what is written, or anthropomorphic phantom? To test the MA modulation system.
Yeah. Well, you know the saying, there are many ways and roads to Rome. So you can even have your own dosimetry phantom tilted in sideways and utilize the head phantom before that. So you can even use your dose measurement phantoms or anthropomorphic phantoms if you want to have a consistent curving related, or to have some mercury phantoms with conical shapes. So there are many ways to have that. In any way, you need continuous changes in the attenuation profiles in Z direction, and you need probably incontinuous sharp differences in there in order to really check the behavior of the modulation system. That's a very, very short answer.
Yeah.
For those interested on this, we have published a paper. We have published a technical note in medical physics on how to use your dosimetry phantoms to evaluate your automatic exposure control system.
And we shared actually a code doing that in proven 5 minutes.
Great.
So, thank you so much.
Yeah.
I have a final question, and because to tell Professor Damilakis that I'm not so pessimistic person, I'm really optimistic. I see in the future that there will be a time that we will be asked to go through simulation machines before we are able to work in clinical environment. In 2 words, the three of you, is this visionary? Will this happen? Yes or no? Will this be beneficial? 2 words, John.
Do I have the option to say I don't know? I cannot anticipate. Nice. Yeah. a nice topic to think about in a summer night. With some, honestly, I cannot. I understand. I'm trying to understand the question, of course, because to simulate. So, is it a kind of test for those wishing?
No. It's a cockpit, like a pilot before going. No, a cockpit.
I misinterpreted your question. So cockpit. The AI can help. Obviously, that's a great question, because some minutes ago I said, and I truly believe it, that one of the obstacles related to training, hands-on training, is the problems in accessibility. We cannot access easily computer tomography systems in the hospitals. So a simulation, like in the air industry, like the simulation machines used there, that would be obviously very beneficial. I don't know if at this period it is a cost-effective solution, because even simulation machines need a lot of money. But yeah, it is a very nice idea, I believe.
Great, thank you, Martin.
Definitely yes. The school training for our radiographers implemented simulation for digital radiography, and I think the preliminary experiences are good. The students are more familiar with projections and exposure parameters coming here, and it would be logical if, in my dream world, it would simply, like John said, when you deliver a new scanner, you should be obliged to provide a simulator the same way as Boeing or Airbus does, so that you can have your staff train before and during operations. So also when updating software, you can try out the new functionalities prior to their implementation of the scanner. So definitely yes.
Thank you.
By the way, just an interruption. Yeah. Sorry about that. But in radiotherapy, those simulation platforms, they exist.
Yeah.
So it is not that futuristic plan.
No, and also we are in place they are vendor-specific simulators, right, that simulate each machine and different software versions. But okay, Mika.
They are great tools.
Final word.
Yes, they are great tools for main functionalities and physical principles, but they are short-sighted to represent complex clinical features at this date.
Great message, great final message. Dear friends, thank you so much. It was a wonderful webinar. Thank all of those that have attended the webinars. And this is time that, unfortunately, we only have 4 webinars. So this is the end of the i-Violin webinars. It was a fantastic 4 episodes. Thanks to all of those that attended, all of those who participate. For those that attended today, you will receive a link to evaluate the webinar. Please do so, because it's very important for us. And I hope to see all of you in the near future. And don't forget that the reason why we are here is because our patients matter and we care about our patients. Thank you so much and enjoy the rest of the day. Thank you.
Thank you. Thank you. Grazie.
Thank you. Bye.
Bye.
Thank you. Bye-bye.
Have a nice spring.